Okay, I think we'll go ahead and get started. Welcome to the Les Turner ALS Foundation's May Learning Series. We're here with Dr. Ann Hogden. But before we begin our webinar today, I wanted to let you know that you're muted and you're not on camera. So sit back, relax, and enjoy. And lastly, this program is being recorded, and you'll be able to view it on our website next week. So let's get started. I'm Lauren Webb. I'm the Chief Advocacy and Outreach Officer for the Foundation. Thank you for joining us today. And the Learning Series is made possible because of Gilbert and Jacqueline Fern Foundation, as well as our industry partners, Biogen and Mitsubishi Tanabe Pharma America. And I just wanted to let folks know that we have some wonderful guides. Our latest guide is on clinical research, so please take a look at that, and as well as our other guides for health literacy. And I'm so excited to have our speaker here today because she is the reason why our materials are so wonderful, because Anne helped guide and teach us about learning about my ALS decision tool and about what decision tools are in general. So thank you so much, Anne. And and a reminder for everyone, we have the CDC, National CDC ALS Registry. So just encouraging folks to go ahead and sign up for that. And coming in June, we have another ALS learning series about how to control your phone with voice. So stay tuned. It will be a wonderful presentation with Eddie from Bridging Voice. So without further ado, I would like to introduce you all to my wonderful colleague, Ann Hogden, who is a senior lecturer and researcher at the School of Population Health, the Faculty of Medicine and Health at the University of New South Wales in Australia. She is a serving member of the MND Research Australia and the MND Australia Collective, as well as the MND Collective Clinical Care Working Group. Her work has been focused on patient decision support tools for MND/ALS Care, and she has authored the first ever MND ALS patient decision support tool in Australia, and she's gone on to assist with similar tools that are in development in the UK and the US. And it is just my honor and privilege to be able to introduce Anne. Without her, none of this would be possible. So thank you, Anne, and I'll let you go ahead and take over the screen sharing.
Thank you, Lauren. It's a very kind welcome. All right. Now let me share my screen. This is the one we want. And I'm just going to put it on slideshow so we can start. There we go. How's that coming through clearly?
Yeah, it's on right now. It's on this. You need to probably swap the display settings because we're seeing notes.
Oh.
So it's up the second quart up at the top where it says display settings.
Display settings. Yeah.
Yep.
And
swap. Yep.
Okay.
Perfect.
How's that? That's so much better.
That's great. Yeah, wonderful. Well, thank you, Anne, for being here today.
Oh, thank you so much for having me, everyone. It's a real honor to come in and talk to you guys today. It's just lovely to be here. So Lauren's given me a wonderful introduction, and I couldn't add anything to that. She covered everything about me that's important to what we're talking about today. And I'm just so thrilled to be here to talk to you about decision making in ALS and decision tools and ALS care. They're the three things that really drive me and my research. It's just such a joy and a great area to work in. So I feel very privileged to be with you here today. I've put my email address just on that slide there in case you want to follow up with any questions or any references that I may have talked about but not provided in the slideshow. But yes, let me know. That's where you find me. All right, and from an Australian perspective, whenever we give presentations, we like to acknowledge the Indigenous country that we are coming from in Australia. And I'd just like to pay my respects to elders past and present on Dharawal country, where I'm coming to you from today. All right, so roughly what I'm going to talk about is give you a little bit of an overview of the Australian perspective of ALS care in Australia, a little bit about me, but not too much, And then we're just going to talk a bit more about the ALS care and research that's taking place that specifically relates to decision-making in ALS care and the decision support tools that were developed. And then we're going to talk a little bit more about how we co-design research for better ALS care with people who live with ALS, their families and carers, and the health professionals who care for them. All right, the Australian perspective. As you can see down the bottom right-hand corner, that's Australia down there, and I am in the bottom part of that, coming to you from Sydney today. As to note, Australia is a very dry continent. All that brown says a lot, and the little green bits around the edges are where most of the people live. We have a large land mass, but very small population of around about 21, 22 million people living here. And so in some ways that relates to what you have in the US and in Canada more specifically, very large land mass. And in Canada, like us, we have a proportionately small population. So that's important to know when we talk about ALS care and services. So as Lauren said, I used to be a speech pathologist. In my clinical care, I specialised with people living with ALS. I also, for a couple of years, managed the ALS specialised multidisciplinary clinic in the Canberra region. So most of my clinical work comes from Canberra, a little bit in the UK as well, but not much. I then moved out of clinical care into research, and my passion was looking at decision-making for care. And so I did my PhD thesis on looking at how people living with ALS and their families and health professionals came together to make decisions for care. And they were very, very difficult decisions that had to be made as the disease progressed. I modelled that, and then I've gone on to look at the decision tool development, as Lauren said, and then in particular in this multidisciplinary care setting for ALS. One thing, in case I slip up, in Australia, ALS is called motor neurone disease, MND, more specifically. So some of the slides will have MND, some of the slides will have ALS, but it's the one and the same thing that I'm referring to. I still carry through with this research, and but my day job is essentially lecturing in healthcare governance, safety and quality. In my personal life, while I don't have any people with ALS in my own family, some of my closest friends have had people with ALS. And yeah, that also the first person I ever came across who had ALS was my accountant. So even though it's a rare disease, it still touches you in aspects that you wouldn't expect, and in your own personal life and circles out there. So that sort of covers me and where I'm coming from and my work in ALS. So who funds ALS care research? Now, this is always a little bit, it's a challenging one. So in the Australian perspective, it's been up to the last 2 or 3 years, it's been very difficult to get funding to run projects that look specifically at ALS care as opposed to cure or treatment. So currently we have Fight MND, who are probably the biggest charity, so the philanthropies, who fund care research grants very, very specifically. And this has been great because it's allowed us who work in care research to launch a number of projects in the last few years. And I think it's allowing us to look at how care is delivered and how we can improve that. And we'll talk a little bit more about that in detail at the end. The other non-government organisation is MND Research Australia, and they fund quite a lot of research each year, but most of it is focused on cure and treatment. And that's quite in line with the priorities of people who live with ALS, because everybody wants a cure for this and everybody wants a really good treatment that either stops the symptoms or slows them down. So we have a little bit of funding coming occasionally from government sources and small amounts of funding in the public and private sector from healthcare organisations to be conducted within their organisations. And so I've been involved with grants in various capacities from all these funding groups through my research career. But as I said, most goes to discovery research. So cure, treatment, and just tend to be lab-based research, and then genetics has also been an emerging area of research, which has been very, very important to looking at how we might be able to cure or at least effectively treat ALS. Okay, so as my focus is on multidisciplinary care, what does it look like? And so we've tried to map it on several occasions, and this is the one we've actually published on, where we see that the person with ALS and their family is core to the treatment in multidisciplinary care. They are the part that we all interact with. And we've sort of got 15 nodes here around it, but that's all we could actually get in the diagram. It's not enough. We find that sort of on the left-hand side, we've doubled up with physical therapy, occupational therapy, speech pathology and dietetics, psychology and social work. But there's so many more disciplines that we could actually fit into this diagram if we had the space to do so. So care is quite complicated. Someone living with ALS is dealing with a lot of different people for a lot of different reasons over the course of their disease journey. And it can get quite overwhelming at times. When you first receive a diagnosis, initially you may be just dealing with the neurologist, but hopefully you're referred to a multidisciplinary care service where lots of different professionals can help you along the way with the care that you need for each stage of your journey. So complex is also in what we see as the sectors within healthcare more broadly who care for people living with ALS. Now, this diagram has come from Samar Aoun, who presented, I think, 2 months ago. I think it was back in March. And I can't remember if she used this slide or not, but it's just to show the complexity of the healthcare sectors around. So we start with the people and we're looking at their own informal networks, and then we go to the outer formal networks and community. And it drives up into service delivery and professional care and even to the level of policy. So it's not just what you're experiencing face-to-face with the health professionals that you deal with every day, but it's also about what's out there in the broader sector and how care is organised within the healthcare world, if you like. Sorry, let me just get rid of that. All right. So complex is the word of choice here. Oops. Okay, so what are the problems with delivering equitable care for people living with ALS? And this is particularly across Australia, but I suspect that a lot of this will also apply to the US and to Canada. We have funding disparities. While in Australia, the healthcare is funded at a national level, and we have a Medicare program where people don't have to, they can attend publicly funded services. And so there shouldn't be a lot of out-of-pocket costs for people for either paying for the services or the equipment that they're receiving. What we now have is a national insurance scheme which has created a funding disparity between people over the age of 65 and under the age of 64. And so what is available to the younger cohort is that they are often fully funded for everything they need. But for people over 65, and that's not that old to me, it's the funding that they receive is a lot less. And so they have to make more specific choices about the equipment that they may spend their funding on. What's the highest priority to them? What is the biggest area of need that they need to allocate their funding to? And so a lot of advocacy work goes on in Australia to try and get equity for people over and under the age of 65 in the funding that they receive. As a big dry country with people living around the fringe, there's also a lot of difficulties with people a lot of inequity, between people who live. Sorry, I might see if I could just turn that one off. Otherwise, we're going to get pop-ups. Oh, yeah, sorry, I don't want to disrupt the presentation, but I'm sorry I didn't manage to turn that one off beforehand. Yes, who live in regional and rural areas versus metropolitan. So in Australia, we have 23 ALS clinics across the country, but most of those are located in metropolitan areas with a couple in regional areas. And so in a big country, if you don't live close to those, it can be a 2, 3, 4 hour drive to attend clinic. And as you know, when you're living with ALS, the fatigue that can cause for a day out at clinic is quite large. There's been quite a few papers written about this in the US setting as well, and how travelling to a clinic is just one of the difficulties that people experience in receiving their care. Now, because of this difference, and because we only have 23 clinics, and it is a rarish disease with only about 2,000 Australians living with MND at the moment. Health professional experience outside of these specialised clinics can be quite difficult. A health professional or a GP or a neurologist may only ever see one person living with ALS in their lifetime, unless they specialise in this area of care. And so the connections between community-based and specialised services become very, very important. So if you don't receive care from a specialised service, but you wish to link in with a service, often we find that the only way to do that, because of the geography, is using telehealth. And since COVID, the blessing that was COVID has allowed us to pursue telehealth and instigate telehealth much more frequently than we used to. We're now able to build those connections a little better than we were, but we're still trying to push that a little bit further so that virtual care and telehealth is a standard of care that all clinics can deliver and that all people living across the country can access to receive their care. So even if they've been able to travel to a specialised clinic to receive their diagnosis and care in the initial part, that they can stay at home and receive their care through their local networks, supported by health professionals who attend the specialised services. And the other area of concern is inpatient admission. So when someone living with ALS goes to a hospital, is admitted to ED, there may not be anybody within that ED services who is familiar with ALS specifically, and that sort of impacts on the delivery of their care, how fast they get the services that they need, and how many questions have to be asked, how many phone calls need to be made to make sure that people with ALS are receiving what they need. That's a whole other presentation and discussion, but I just thought I'd touch on it here. The other issue we're having is that in Australia, we don't actually have national care guidelines, and it was great to see that Canada has them, New Zealand has them, and the UK have them, and that Lauren's referred to the guidelines that you received at Les Turner Foundation. So that was great to see. Okay, I'm just going to move into the decision-making part for ALS Care. I've got a clock right in front of me, so I'm just keeping my eye on the time. So when we talk about decision-making, there's two sides to decision-making. The first one that comes to mind is what health professionals call clinical decision-making. And I've put this diagram in here that comes from the Canadian guidelines that shows you what drives the decision-making. And this is particular for nutrition issues and perhaps for PEG insertion, PEG or RIG we've got here in the diagram. As you can see, it's very linear. So we start with monitoring weight, we go for criteria to the intervention, and we go across to considerations for that. And so we can see there's a nice flow chart, a nice flow path that clinicians can take to initiate discussions with people with ALS about whether they should be considering a enteral feeding or a PEG tube, a gastrostomy, something along that way. However, when we look at how people with ALS and their families, the processes they need to make decisions, this is how it's modelled here. It's very, very circular. It's not linear. It goes back and forward, back and forward. And so this is what I actually did my PhD on, and this is the model that came out after I spoke to people with ALS, their carers, and their health professionals at 3 different ALS clinics across Australia to learn how decision-making was made and how it was carried out. And what we saw is we have the process of engagement and then information sharing about the decision made. So gastrostomy is the one that I tend to use as an example. And so we can see that we can talk to people, we can give them information, but the time that people need to consider that information and deliberate whether, say, getting a gastrostomy is the right decision for them can take quite some time. And we see the arrows show that people go back and forward, and have further discussions with their health professionals, further discussions with their family members before they weigh it up to see if it's the right decision for them. And then they can move forward to actually having that gastrostomy, for example, implemented. So having that inserted, the hospital visit that entails, all that. And again, we can go back and forward. And then once we've decided what we're going to do about that, we can then move back to the next decision that might need to be made. So example, getting ventilation to assist with breathing. support. So that's roughly what, a very basic level, what decision making for someone living with ALS may need to go through. And you can see it's quite different from the linear process that clinicians make. So decision support tools were then designed to make that process a bit more effective and give better support to people with ALS to make informed and well-timed choices for their care. The decision support tools have existed for quite some time in many other conditions, and Parkinson's and disease and multiple sclerosis have a couple of examples out there. And these actually all come out of Canada. There's a register for the Ottawa Hospital decision tool, international register, which you can look at and see what decision tools are there. But there was nothing for ALS. There is now, but there wasn't back in 2015 when I started looking at how we might develop decision tools to help people with their discussions. And so the advantage is it allows people to have well-informed and hopefully better timed decisions for their care, because as you know, some decisions have to be made within a certain time window. They also help to promote discussion between people living with ALS and their families to make the right choice for them, and that's something that's in line with their own priorities. And then it also, of course, the decision tools provide a framework for clinical care discussions with the health professionals. And so tools are available, they're on the internet, they're available for people with ALS to use at any time they want to have a look at them. They're not something that's contained to a clinic visit, and also means that health professionals can use them in the clinical visit, but they can also look at it in their own time to see what's out there and available to help promote those discussions. So that's what we think decision support tools, or decision aids, as they are sometimes called, are good for. But making choices for ALS care is still difficult. And why might that be so? And there's a whole lot of reasons out there, but some of the ones that come up more commonly are that acknowledgement that change is happening in the ALS disease progression is difficult. It's not easy to say, you know, my swallowing was okay yesterday, but it's not so good today. Something's happening, something's changing. Because as we know with ALS, it is a long or short or fast, sometimes steady progress. Once things change, that change is permanent. It doesn't always go back and forth as it may do with other conditions such as MS. So just talking about this change can be quite uncomfortable for people with ALS and their families, but it's also uncomfortable for many health professionals, particularly those who don't have a lot of experience in this field and are trying to help people with ALS. Sometimes for clinicians, it's very difficult. They may see that the person with ALS has had a change in their condition, and it may be up to the health professional to raise that point with them, to open that discussion up, to talk about, what do you want to do about this? This is happening. How are we going to look at this? And what does the future look like? Because the future is a scary place. And so we also then have to think about, when is the best time to have this conversation? Ideally, it is a proactive conversation rather than a reactive conversation. So sometimes when a person with ALS receives their diagnosis, within those first couple of appointments, the clinicians will hopefully have spoken to you about what decisions may come up with your particular disease course. So, for example, if we're looking at a PEG, some people wish to have the PEG inserted as they're just showing their first signs of swallowing difficulty or respiratory difficulty, or if perhaps their disease course tells them that this is likely to occur further in the future. So the timing isn't easy, and it's not easy to predict when it's the best time for a person to have something done, like a PEG insertion, or start on ventilation support, so non-invasive ventilation, for example. It's very, very individual. And again, it's all around how comfortable people are having these discussions with their clinicians to instigate those referrals, to have these things take place. And then we look at who should be involved in these discussions. Is it just the neurologist and the person with ALS? Do they include their family members in these discussions? Hopefully so. Do they discuss it with all the team members who may be involved in this? So again, going back to PEG or NIV, is it just with the speech pathologist and the dietitian for PEG, or do we talk about it with the speech pathologist and the respiratory therapists who could be involved? And then we ask people to think about, what does this decision mean for me and my family? So again, if we look at gastrostomy as an example, once somebody has a gastrostomy inserted, does that mean they can still partake in family meals? Or does it mean that they will have separate feeds? Do they sit at the table with the family during the dining hours? Those kind of things that need to be talked through in longer discussions about what's the impact. Once I have this intervention, NIV, gastrostomy, for example, how does that change my family life, I suppose? And then the other question becomes, what happens if I say no? What if I don't want to have this intervention? What are the consequences for this? How do I know that I'm making an informed decision about my choice for yes or no? All big conversations. And so we find what influences these decisions in ALS care for people who are looking at having something, an intervention such as gastrostomy. How does it fit in with their personal values and preferences, and how would they normally choose for themselves? And one thing people will often say, I didn't want to rely on equipment or technology to extend my life or to make my life easier or improve my quality of life. And that's something we all sort of look at maybe before we receive the diagnosis of ALS. But as you live it out day by day by day, sometimes those decisions can change. People then decide, well, what is my quality of life with this disease? What's the best way that I can live with this? And what does quality of life mean to me? Because we often find that people have very, very different views of what is quality of life. For some, quality of life is not depending on any kind of equipment. But for others, it may mean being able to be around with their family, living with a gastrostomy, being able to partake in family occasions, interventions, even if it means you can't actually eat orally anymore. And for some, it's about pleasing family and friends and maintaining the roles that they have within their family, still having a voice within this and being able to carry out the functions that they did within their family, and that something like a PEG or ventilation may help them actually do this. The other thing that people with ALS have told us that they consider is their perceptions of the burden that it places upon their carers, so their family carers. So for some people, they don't want their family members to have any burden in looking after equipment, making sure that they're interacting with services to have the equipment maintained or replaced, that kind of thing, the day-to-day care. And so they decide, well, I don't want to burden my family member with that. Whereas other people see that this is something that their carers are really very keen to have in place, and that it's a good connection between them and their carer to work together to care for them with this equipment in place. And so that becomes a discussion within families about, what are your priorities? What is the most important thing to you now? And how does that carry out for the disease journey as it progresses? And then some people change their mind. So that's okay. It's just all about the timing of when you change your mind and what's important to you right now about having one of those interventions in place. So there's a couple of papers where we've discussed this, and Julie Labra's paper that we first published back in 2020 has a little bit more detail about that and the differences between people living with ALS and the choices that they made and how they may have changed their mind over the disease. And we're writing another paper at the moment that's about to be resubmitted to the publisher, and we hope that will be out soon because that discusses this in a lot more detail. Right, decision support tools or decision aids for ALS. In Australia, there's actually 2 tools. I've only put the one up because this is the one with the site with the biggest tools. So these are all the links to the Australian, the UK tool, the US tool, and one that's come out from Spain. That's the most recent tool. It's in Spanish, but you can also click on the translation button for English, but it's also in Catalan as well, because it comes from Catalonia. So I've put those links in there if you wish to have a look at them. And I've just given a few screenshots. So this is the original tool that we developed back in and launched in 2018. And that's the main Australian one. In England, in the UK, this is the gastrostomy tube. So Sally Wheelwright and her team developed this. And this is one where if you click on the link, you can go and you can register for it and have a look at the decision-making tool there as well, if you're interested in having a look. And our next one, of course, is the lovely Les Turner tool that Lauren and her team developed. And this is Lauren showing you in the screenshots as well. And hopefully you know where to find these. And Lauren, I believe, also did a presentation at the 2023 International ALS Symposium in Basel. So I'll post a presentation there. And this is the one from Spain as well. So just to show you what it looks like roughly. All right, in this last part of it, the tool we're going to, of this presentation, we're going to move on to co-design. Now, in ALS care research, co-design has become a very, very important aspect of the research that we plan and carry out. And so this is nothing without me, nothing about me without me is a saying that comes from a long time back. And it was, I think, applied originally in inpatient care, so that when somebody goes into a hospital, any of the discussions about them or the treatment decisions made should be in consultation with them. So they shouldn't find out that they're receiving a new medication, for example, when the medication is suddenly dished up to them. They should know about this in advance because the clinical team have discussed it with them. And so when we apply this to ALS, we look at how people with ALS participate in research. So people such as a gentleman called Murray Gill, who was a participant in an ALS cure research project, found that his experience was very negative, because when he joined that research as a participant, he was not consulted in any other way within the drug trial. So blood was taken from him, other things were taken, but he never received in his lifetime any feedback about the process and how that all impacted and what the results were of this study. And so he found that a very, very difficult thing to conceive and to experience. And so he wrote a charter about how he felt that people with people with ALS should be treated as part of their research journey. And so what we now talk about when we talk about co-design is that continuum of whether people are just participants in the research, whether they are consulted as stakeholders in the research, or whether they are part of the research team as owners and partners. And ideally, this is what we have in ALS care research, where there's a member of the research team who is somebody living with ALS and they're also their caregiver. And so in Australia, in part of hospital accreditation that takes place, it's actually a requirement that services partner with people in the community. This is not specific to ALS, but just anyone who's undertaking hospital care, and so that services can be designed or consulted with people who are part of that disease group, so that the care that they receive is actually tailored to those people receiving it. And so when we talk more specifically about care, co-design of decision support tools, this is how we ensure that the tools will actually be useful to people living with ALS, their families, and the health professionals that we'd like to use these tools once they're developed. And so we co-design with stakeholders as members of the research team when we plan what the decision tool project will look like. So how the tools will be developed, what they will look like in their finished state, and how they will be rolled out into healthcare services. So from the design and the trialing of the tool and participating in the implementation, but also after the research project is finished, because many of them are 2-year projects, 5-year projects, they don't always go for a very long time, while they may take a very long time to develop and roll out. But we know that when we have people with ALS and their caregivers and also the health professionals who work with them involved in a project, many times they're able to give us feedback on how things are going after the project has been implemented and during the evaluation times, but in that long term. And that's very, very valuable information to us, because it means that we can change perhaps the tool we've developed or the implementation process that we've put in place in an ALS care service. So currently we have a number of projects underway that were funded by Fight MND, and these all involve people living with ALS and their carers and health professionals. And so the top one is the one that I'm currently involved in. So as you know, I developed this set of decision support tools. We were only able to develop 3 at the time because we didn't have enough funding to complete a suite of 6 that that people with ALS had told us that they were the highest priority tools for them back in 2015, 2016. And so we need to update, because it's 2024 and it'll be 2026 before we actually get these underway. And so we want to make sure that they are the most relevant, because things have changed in the ALS landscape. Particularly in Australia, we have new legislation, we have different community expectations. And so we want to make sure that those tools are relevant. And so my colleagues have also been funded to present these projects. So we also have one that looks at co-designing solutions to target the barriers to non-invasive ventilation uptake, because we know that not everybody who could benefit from non-invasive ventilation has been able to access it or use it. And we want to know the reasons why and what we can do to reduce those barriers. And so we were also looking at consumer experience as a perspective for improved models of end-of-life care. And that's one of the projects Samar would have spoken to you about in March. But she also, Samar has many projects, but these are the 2 that are on the current radar, that she has a person-centered approach to family care needs, to assessment and support. And so currently we're rolling out the Care Alert Thermometer across Australia, and that's a tool that is specific to carer needs, and that's something where carers can look online and click a few boxes to indicate the needs they are experiencing, and then be linked up with services to help them. And so that's national across Australia. And then Julie Labra is looking at access to telehealth in remote, rural and regional New South Wales, and then further on we're actually going national with that one as well. The initial project was New South Wales, and then we'll look at it doing a national rollout after we've co-designed that for a better version of telehealth and virtual care. And then the final project I'd like to sort of highlight here is in the Central Coast, which is a regional district of Australia. They've tried to develop a clinic, but the clinic has had no funding. And they're looking to see how they can make this clinic as effective as possible with good, strong multidisciplinary care, and how we can integrate that care so that the ALS clinic in the rural areas is as strong as it can be. And they're currently trialling this clinic and looking for new ways to have it funded, so that it's there for the long term. This project is actually a huge testimony to the devotion of people with ALS, their carers, and the health professionals who have come together and not been funded to do so, to run a clinic every 3 months. And the clinic is just growing gangbusters, but it actually needs to be seated in an organisation that can fund it in perpetuity, if you like. So that's the main part of my presentation. If you'd like to do the questions, Lauren, tell me what people would like to know. What have I missed?
And you really definitely covered a lot of the key topics, right? And I really appreciated the circular decision making. And that's something that, we see all the time with families and revisiting, choices And things change, right? As the disease changes and as the family dynamics change. And so that's really, thank you for highlighting that. And I think that was something in partnering with co-designing with people, we heard that time and time again, like it just changes. It's not absolute. And being able to use tools to revisit when they're in a different place is helpful. And I think you really definitely touched on some key things, with Murray's story. Similar in the US, a group of people created the Morris ALS principles to
Yes,
be able
yeah.
to have that impact, as well as the International Alliance Fundamental Rights. And I think it's been really amazing to see how the landscape has changed and grown. And we are in deep gratitude for your work, because it really has informed how other organizations go about doing this. So I just wanted to offer those comments. And lastly, I think you're spot on about the research. There's not that many researchers who are funded and able to do this work to evaluate not only just decision tools, but also how care is administered. And that is a critical piece that we all need, because through those surveys and interviews, we learn and glean so much. So we're deeply I love Australia because of all the connections and the papers. Your papers continue to inspire us, you and Samar's papers, to be able to think about different ways of not only just design, but also interactions, right? And how we work with people. And I think that's a big piece. One of the questions that was hit on was, and this is a tough one because and we know this is a challenge that families face, is one of the questions that came in earlier was, when your loved one with ALS has ALS and is demented and can no longer communicate what their wants are, how do you determine how to prolong life?
It's a very, very difficult question. And when I spoke before about decisions and the timing of them, I think that plays into it. If we've had these discussions before, people are either unable to communicate well, or the dementia is part of their disease, sometimes you can say, well, I know that we've had this discussion. I know this is what my loved one would have wanted. But if those discussions haven't happened, it's very, very difficult, because you're sort of faced with looking at the person with ALS and deciding, how do I understand their quality of life at right now? Do I see that they're enjoying life, having a good quality of life, or is this something that is distressing them so much that prolonging life would be an agony to them? It's very much about knowing that person and what that person would have wanted for themselves. It's also difficult. The dementia component, often people change on what they might have wanted, and being able to live as long as possible becomes a very important thing to them. Having said that, when we've done our research on decision tools and interventions to prolong life, it's very rare that people will take up an intervention solely to prolong their life. Usually they focus much more on the quality of life they have and living as best they can for the time that they have left. And so, while it is difficult to see, sometimes you can make that call for that person, because you know that they don't necessarily want to live every day that could be allotted to them, and prolonging that is probably not a priority for them. So again, a very, very difficult call, but it's about how well you know that person and how much you know that they appreciate that love and care that you're giving them.
And is there any good tips about, it's not like you say, okay, we're going to have our decision discussion, right?
Yes.
Like what tips, would you give to families to help drive these conversations, and what does that look like in reality, right? Because they're not, walking through this in a very linear fashion as they would with the tools, but it's often the conversations after information has been presented or they've been thinking about it. So could you give us some tips?
It's a tricky one, and it's often when you're in the right headspace for most of us, and coming from outside the ALS community, this is often so in my family, give you an example. Being able to talk to them when they were getting older about what they actually wanted for their funeral. And that particularly was a difficult discussion. And some of the members of my family, my dad, for example, was very, very specific in what he wanted. And the discussion was held many years beforehand. He was very specific. And my mum also, she sort of, after my dad's funeral, she said, well, I want one like that. So, and then my auntie said, well, I want one like your mother's. So it's a tiny example, but it was just something that, in the context of what was happening, it was kind of easy to talk about that discussion, that decision. And so sometimes it's after you've come home, after the clinic, maybe a day after, and just raising that, okay, well, the doctor said this, the speech pathologist said that. What do you think? Is that something that you want to look at and talk about a little bit more? Do we want to have a look at what information is out there? Is there somebody else we want to talk to about that? Is there somebody else we know who's been through this journey and has made that decision for themselves? And is that somebody we can talk to? So it's very, very much context dependent. It's never easy, but it's about knowing what information is out there that's good for you and that can help with this discussion. One of the things that people with ALS told me is they often defaulted getting that information to their carers. And so some carers told me they were up late at night looking for information that the person who had the ALS didn't necessarily want to look at because they found it too confronting or it was too difficult. So often it's about the carer initiating this discussion and initiating, well, this is the information I found. What do you think? So a lot of it is put back on the carers at times, but they're the people who often drive this, and they're the great advocates for people who are living with the disease. I hope that's answered your question. It's not a very
No, it does.
direct answer, but
Yeah,
it's
no, but it's important, right? Everything
yeah,
happens in context, and stops and starts, and the drive
round and round
home.
and round.
Yeah, yeah. I mean, it's all part of that. The when you were talking about the clinicians and the linear process, of decision making, as they help guide those conversations, and I know some other work that you've done around looking at high functioning multidisciplinary clinics and the different roles. What tips would you give to professionals to be able to um, help guide those conversations and set the right tone, and be there to support whatever decisions that people make? But any tips for those professionals?
Yeah, I think professionals never work in isolation. So you're part of a team, even if you're not even physically co-located, but for each team, there's generally a counsellor or a social worker who works on that, and they are experts in introducing difficult conversations. From my own clinical experience, I worked in a clinic that was actually palliative care run, not neurology run. And so the palliative care team and the rehabilitation team were the two groups of health professionals that came together, and I learned so much from my colleagues. I was an experienced speech pathologist at the time, but having conversations about interventions to prolong life or interventions to improve quality of life was still quite difficult for me personally, even though I'm trained as a therapist. And so I learned a lot from the social workers I worked with and the counsellors, because we could sit down and talk about and prepare for that conversation we felt would come up in the next appointment that we had with someone with ALS. So they were great resources, and just being really well informed about the information that's out there about the particular intervention you're talking about, even if it's just a communication device. Now, the communication devices we use are so friendly. They're our phones, our iPads, that kind of thing. It's equipment you already have. But back in my day, there were clunky things that you had to order in that were very obvious in public that somebody had a problem. And so I'm really thrilled to see that new technology has reduced that for people. But sorry, I'm starting to wander off topic there.
No, I mean the changes of technology and things aren't as large, and they're smaller, and it becomes part of our culture, right? Like everybody
Yes.
is utilizing different devices, to function, and so this is now just an extension of enabling folks with different ways of communicating. So I think and there's a lot more that needs to be done to improve these areas. And I think that co-designing with people living with ALS to be able to help with that process. Was there anything surprising to you in your interactions with people living with ALS as you were co-designing, what were some like big aha moments for you personally as your tools evolved?
I think it was, well, firstly, when I did the first decision tool set, it was just the high level of agreement that we had between people on what were the highest priority tools. And so the 3 tools that we developed, which is similar to what you have at Les Turner, is that we had the gastrostomy tool, we had the non-invasive ventilation, and at the time it was about predictive genetic testing for family members. So they were voted above and beyond by the people living with ALS as the highest priority. And then there was a whole range of tools that sat under that. But I was really surprised to find it such a clear decision. These were the things that were most important. And I was absolutely delighted with that, because we went through rounds and rounds of voting processes to make sure that we accurately picked the most important or the highest priority tools to people. So that was one of the things that really leapt out at me. But the second thing I think then in other projects since then is the diversity and what quality of life means. And I sort of spoke about that before. So for some, it just wasn't prolonging anything. It was getting this disease over and done with to release my family. For others, it was being able to stay in my family and be who I am. And so, yeah, that's 2 very different attitudes, but and huge variation within them both. So, yeah.
The what matters most, right? And trying
Yep,
to work
absolutely.
through that whole process and think through and you know, for us, and we were so grateful because we built off of Ashley. We just borrow from the Australians. We built off of your work with Ashley on predictive testing, and we just recently launched that a few weeks ago with family members who are considering genetic testing, because in the US they just released some guidelines with regards that to all people living with ALS should be offered genetic testing. And so we were really concerned about what are the ramifications of all that information, that will be coming to families and helping to support them. So we're really, really grateful for Ashley and all of her work with helping us launch the tool, this month. And what's next? What's the next tools that you're going to be working on, Anne?
Well, because we haven't consulted yet, we don't know. But
Yeah.
from discussions I have had and heard people with ALS saying, getting the genetic testing for people who have ALS, so the diagnostic genetic testing to see if there is a gene influencing their disease and their disease course, more importantly. Yes, so that's something that I'm hoping that people with ALS will be wanting. And based on discussions we've had, I think that will be a big hitter. The other thing in Australia, across the country now, voluntary assisted dying has come into legislation. We didn't have that before anywhere, and it took many, many years for people to actually get this into legislation. And I know when I first met Lauren back in 2019 over in Perth, that was the same week that legislation came through over in Western Australia, and it's been rolled out across the country. And so we want to know if people with ALS are wanting a decision tool to consider their options in voluntary assisted dying as it is available to them in their state. So that's going to be a very new area for us to look at and dive into, to create a decision tool if they prioritise that one. And I think the other, sorry about my pop-ups.
We don't see it. We don't see them, Anne, so you're all good.
Oh, good, because I'm really embarrassed. They're from a writing group that I belong to that's normally at this time, right? I think the other one may be around end-of-life care and how that looks for people with ALS, and what are the options available to that, because there could be many depending where they live. So that, off the top of my head, they're probably the ones. Medical cannabis may or may not come into it too, because that's something that's come into Australia relatively recently as well. So.
And responding to the needs, of the community that you serve. And that's why there are different decision tools, because they take place in different contexts. And I think
Absolutely,
that's
yes.
important, and language. We are just deeply grateful to you for this work. And we have really grown because of this work. And I think we have grown because of people living with ALS and the carers who inform all of our decisions about how to move forward. And I'm beyond grateful for the scholarship and also for the people who fund these tools and this research that I think is really important. I think Samar's talk, she said, you know, you're only at clinic for a small portion of the time, right? You're living your life, you're interacting, you're having those conversations. You might be working with an ALS organization, but you know, having information and materials in people's hands is it's really powerful as they can have those conversations as a family and make choices for what matters most to them and their quality of life. So we're grateful again, and thank you for joining us today, and thank you for folks who are listening. And I don't see any other questions in the chat box. So
Yep.
Go ahead, Ian.
Sorry, these are just the articles that were referred to in the presentation if you want to read more. That's all.
Yeah. They're very important. Thank you for being a library fairy for all of us as we work through these things. So thank you so
Thank you
much,
so much.
and have a good morning to you and
You
everyone in the US. Have a good evening, and we'll talk to you soon. Thanks so much,
Thank
Ann.
you, Lauren. Okay, bye-bye.
Bye-bye.